Welcome everybody to the SSAT Virtual Grand Round Series. And this is a series that we host amongst the various fellowship locations on topics of mutual interest. And today we have really a very interesting presentation from David Fahn from his SSAT program on desmoids. And David, I thought maybe you'd tell us something about yourself and how the program's been for you so far as you get us started. And the floor is yours.
Good evening, everyone. So I am the current MIS and Advanced GI Surgery fellow at Valley Hospital. That's located in Ridgewood, New Jersey. I did my training in Queens, New York at Flushing Hospital. After training, I decided, I wanted to get more experience in the robotic realm and applied for MIS fellowship. So that got me into Valley Hospital, where we do a good amount of bariatrics. My fellowship director and also program director, Dr. Melissa Bagloo, she's on the line right now as well. She does bariatrics, but I do get a lot of exposure in other specialties such as hepatobiliary and pancreas, general surgery. We do a lot of general surgery stuff here, and most importantly, some surgical oncology as well. So that's why I wanted to kind of present to you guys some of the cases that we got this year while I was here.
Great. You have some real interesting cases. It's a fairly long presentation, so we better get you started.
Yeah, hopefully we can get through all of it. All right. My assistant program director, Dr. Pozzessere, he might not be on right now. He was stuck in the operating room. We had a pretty long case in the morning, so everything got delayed. All right, so we'll discuss 3 cases today. The first one is a 46-year-old female who presented with 5 days of progressively worsening abdominal pain associated with some nausea. No major medical problems. She had a previous surgical history of a lap chole and a right oophorectomy 15 years ago. From what she stated, it was she had to get her right ovary removed when she was pregnant with her son because it ruptured. A family history was significant for colon polyps in her mother and also a brother who's actually in the age of the 30s. So this was the CAT scan that was obtained when she first came in. She had been found to have 3 liver lesions, all less than 3 centimeters in segments 2 and 5, and also this 8.7 by 7 centimeter heterogeneous mesenteric mass. This was abutting and inseparable from the transverse colon, and also a fibroid as well, incidentally found. So next, we ended up getting an MRI that was obtained as well. This was able to better kind of characterize the findings that we got on the CT scan. There was 3 hemangiomas, all less than 3 centimeters, as well as a 5 centimeter segment 4 focal nodular hyperplasia. The mesenteric neoplasm was measured to be 9 by 8 by 7 centimeters between the pancreas and also the transverse colon, with some mass effect on the SMV posteriorly. And they read it as a third of the tumor actually demonstrated some necrosis. So that brings us to the first question that we had. What are some differential diagnoses that we could all think about?
This is where we want the fellows to participate.
All right.
Philippe.
Sorry. Maybe a desmoid tumor?
Well, yeah, that's what we're going to be talking about. So in regards to mesenteric masses, obviously you don't know that it's a desmoid tumor from when you're first evaluating the patient. So when imaging is done. The first step is actually to determine if the lesion's cystic or solitary when you're determining any type of mesenteric mass. Obviously, solid masses are usually neoplastic, whereas lesions that are entirely cystic are typically benign. Signal characteristics, morphology, and also enhancement patterns can help further narrow down your differentials. So regarding our solid mesenteric tumors, presence or absence of adipose tissue, contrast enhancement, and also the delineation of the tumor borders are essential in characterizing these masses. So for this patient, based on the CT scan and also the MRI, we were suspicious for actually GIST versus a fibrous neoplasm. So she ended up getting a upper endoscopy and also a C-scope. EGD found some esophagitis and also some ulcers, small hiatal hernia, but biopsies were insignificant, just some chronic inflammation, negative for H. pylori, and colonoscopy was also done, which showed extrinsic compression of the distal transverse loop, transverse colon, but was otherwise unremarkable. And then that area was actually biopsied, which did not show any type of inflammation or dysplasia.
So David, let me ask you, what if those liver lesions were more indeterminate, what would you have done with those?
We should have, if they were indeterminate based on the MRI or a CT scan, we would most likely undergo a biopsy of that. IR biopsy is an option as well.
Yeah, that sounds reasonable. And could you tell exactly where this was coming from based on the imaging?
Of the liver or of the actual
of the
mass?
mesenteric mass.
It's hard to determine, but it seems like it was coming off of the transverse colon and also the mesentery there, based on the imaging.
And had you had any prior imaging? Because often that can be very helpful.
We did not have any prior imaging of her.
Okay.
So that brings us to our next question. What is the next step in management for her? What would you guys pursue after finding out those results from the imaging and also the upper and lower endoscopies?
Matt, I'm sorry to join late. I apologize, but feel free to pick on anyone, Matt.
Oh, I have been. You've just missed it.
I'm sorry, I missed the beginning. Was the patient symptomatic from this mass?
Yes, she had some. She came in presenting with abdominal pain, some nausea. It was subtle for about a month, but then it got progressively worse, and that's why she presented to the ER.
Well, I think if there is a suspicion for just neoadjuvant Gleevec might help to shrink a huge tumor like this, but other than that, I guess proceed with surgery might be another option too.
Is there anything anyone else would want a little more definition on based on the imaging we've seen so far?
This is Paula speaking from CMC. I think the concern right now is he said that the imaging that is avoiding the SMV. So I'd like to at least recharacterize that lesion to be sure that there's no true involvement of the SMV. If that's not the case, then in that situation, potential excision. If it is the case, then I'm not sure if salinidac is still an option for this desmoid patients, but that might be something we can consider to maybe downstage it and then do an excision later.
We don't have a biopsy yet, right?
No.
We don't have anything at this point.
Yeah, so I would probably start with US biopsy of this mass.
Okay.
So I think my point on the mesentery would have been the same, which is I couldn't really see the vasculature very well of the mesenteric artery and vein. And sometimes the coronal helps with that, obviously, but you really want to know what that's like before you jump in. Dr.
Matt, just a question for the group. I'm sorry, I missed the imaging, but the differential here, at least that people are talking about, are GI stromal tumors and some sort of desmoid fibromatosis. Is there any other imaging test, David, that would be helpful in delineating those two entities?
In regards to GIST versus a fibrous tumor? Not that I know of.
Yeah, so one thing that can be helpful is a PET scan because GISTs are typically very hot on PET. Matt, you might, I don't know what your experience is, but usually desmoids are not on PET. And so that may be helpful. And just speaking to Felipe's comment about EUS, are you at all concerned about spill if there's an EUS of a GIST that's, not directly intraluminal?
So because it's difficult to get PET approved for just a mass lesion, we're not going to probably do it. And none of my oncologists would give any molecular chemotherapy without having a biopsy. So typically, if we need a biopsy, we're going to go for that, is what I would say. Do you want to go back? Can you go back and show? Rohan really wants the imaging. Go to the CT at least. There you go. I would say just remember a lot of these don't, they get a routine scan. So that's where the SMV, you just have to look at closely. You went past it a little bit, but it's better on a CT to me than on a MR. So right there is you just want to make sure you have that plane there. Any other thoughts on the imaging? Rohan, Alex, I saw Alex on.
Dr. Cho, he's my partner over here. What do you think, Eddie?
I'm concerned. It looks like the tumor is huge, and it's going to be very. I mean, it's near the root of the mesentery. I do see what Dr. Walsh is pointing out with that little sliver of fat in between right there in that cut, but I'm concerned about this in terms of vessel involvement.
Alex, are you on?
So Rohan, it's Imran and Matt. I know, just for full disclosure, I don't do this operation, but why can't we get a bigger biopsy to figure out what it is before we go charging in? If it is a GIST, then you can give them Gleevec. If it's a desmoid, you can try something else. Why does going up front surgery the first choice? And again, just for argument's sake.
Hello.
Matt, you want to take that?
I think he's on the phone.
Oh, so I think from my standpoint, and please jump in, people that are more expert at this than I am. My concern with the GIST is that if you have intraperitoneal spread from a biopsy, some of these things are very vascular and have quite a bit of they can be somewhat fleshy. And so once you biopsy, you can get spill. And then my understanding is that those patients are now considered peritoneal disease. So I'm nervous about biopsying GISTs in general, Imran, unless, most of these are intraluminal gastric, obviously the duodenal ones, etc. So for me, I think that this is, as Eddie said, I think this is close, but I think it's potentially resectable. But I do think that the differentiation between GIST and desmoid is probably going to be critical. Matt, thoughts? I think he's still on the phone. Is that right, Matt? Are you on the phone?
I
think the issues are whether it's where it's originating from. That can help. That's why I asked that earlier. Just typically aren't off the colon usually. And I agree, you don't want to biopsy something and potentially spill intraperitoneally if you can already resect it. So the goal of downstaging or downsizing is really to change the operation. If the operation's the same, then there probably isn't an advantage to doing that.
Alex Rosemurgy here. This looks to be resectable. Why not take the patient to the operator and put a scope in? If you see something that changes your mind, you biopsy, take care of it. That may help with staging, may help with diagnosis, but this looks removable to me. Is there a reason why it's not? Or are you worried about taking out too much colon, I don't think small bowel. What are your thoughts? Why not just operate on this patient, take care of the problem?
No, I think that's what we're all talking about. The issue is only how do you review the imaging and make sure you're comfortable removing it. So I think in this case, it's all about the mesenteric vessels. So
the SMV and portal vein are clearly free. I didn't get, I've been distracted by my phone, but I didn't go to look at the SMA and branches, but portal vein SMV is certainly free. As we roll through, we can look at the others. SMA is free.
What about the liver lesions? Does that change anything? Do we think?
Well, I didn't.
No, they're very characteristic for hemangiomas.
Okay, so we're not worried about them.
No. Okay, the point is to review the imaging well, make sure that you can resect it if you're going to, because the patient is symptomatic, right?
Correct.
Okay.
So that brings us to this flow chart. In regards to that, everybody was correct in regards to kind of evaluating what these characteristics are and if this is kind of resectable or not, or if it's malignant or benign. So obtaining tissue diagnosis or formal resection is determined by multiple factors. So for asymptomatic tumors, the dilemma is actually to rule out malignant or pre-malignant pathology. For symptomatic tumors, which this patient does have because she presented with abdominal pain, one must choose the appropriate treatment, which may in some cases be non-surgical, like a lot of people were talking about Gleevec or NSAIDs for if it's desmoid. So biopsy must be considered in the context of the tumor's actual resectability, as we discussed. So in regards to our patient, the white count, remember though, we did mention that a third of the tumor was necrotic appearing on the MRI. So the white count was noted to gradually increase during her course while we were kind of working her up. She ended up having a white count of 19 with several episodes of fevers. So likely secondary to this necrotic aspect of this mass. So she remained symptomatic with persistent abdominal discomfort and also pain during her stay. So after extensive discussion with her in regards to, biopsy versus resection, we just actually proceeded with a surgical exploration and potential resection. So when we entered, we saw this mesenteric mass that appeared right off of the transverse colon, and it was growing posteriorly in the mesocolon and pretty much abutting the pancreas. And during the dissection, the mass and abscess cavity was entered, which was cultured. Came back pretty much negative for anything very suspicious. It was multiple organisms that were found, pretty much just colonic. And frozen sections of the mass were sent during the operation, which showed low-grade spindle cells. Now, the frozen section was also sent from the pancreas margin, which was negative. The mass was then carefully dissected free, and then we did an en bloc resection, doing a transverse colectomy with a primary anastomosis. So on final pathology, it came back as a 11 by 9 by 8 centimeter mass involving the outer portion of the colon up to the muscularis propria. Spindle cells were present with absent to minimal atypia and rare mitotic figures. It was positive for beta-catenin, which is pretty pathognomonic for mesenteric fibromatosis. Patient had a pretty relatively uneventful postoperative course. Now, that brings us to our question now, even though the posterior margin on the frozen was negative, if it did become positive and there was abutting the pancreas, how would you proceed intra-op?
One of the fellows has to volunteer.
Annie, do you want to take this on?
Sure. I mean, I think it would be, dependent on what you were going to do adjuvantly after as well. So what your goal here is to relieve obstruction and not necessarily for a full oncologic resection. So if I was going to choose between a pancreatic leak and a positive margin, I think I would pick a positive margin.
Unless you're Dr. Walsh, right? Because none of his pancreases leak. So
yeah, it's a, you had the diagnosis. I mean, they do typically resect completely in a sense, meaning you shouldn't be going across any of these tumors, whether it's a GIST or otherwise. So it is a surgical disease though, not a non-surgical disease. So whatever it takes to get it out is what I would say you should do. But you wouldn't come across the tumor, get a frozen section, then decide to go back and resect more, hopefully. You want to do it en bloc.
Before I did that, Alex here again, before I did that, I would make sure it's not lymphoma or something which is amenable to other forms of therapy.
And David, were you concerned at all that this had fistulized into bowel and that's why she had this abscess? Was there any suggestion that you had a fistula to bowel? Because that can sometimes happen with these.
Yes. So once we got into the abscess, we were pretty positive that there was a tract to the colon. So, I mean, the microbes that grew out of it, I don't have the exact cultures, but they were of colonic flora. So it wouldn't make sense that it was invading and fistulizing into the actual colon, the transverse colon.
And you didn't have to resect colon though?
We did the transverse colectomy. So it was an en bloc resection because the mesentery of the transverse colon was involved. All right, so now that we have the actual diagnosis, and today's talk is going to be primarily about desmoid tumors and how, so in historical context, Mueller in 1838 coined the term desmoid tumor. The first description of the tumor is actually accredited to McFarland, who actually reported the disease occurring from the abdominal wall of a young woman after delivery in 1832. Desmoids are benign, slow-growing neoplasms that belong in a group of tumors of the fibroblastic origin, characterized by local aggressive growth and also relapses, but without metastatic potential. It is a rare tumor accounting for 0.03% of all neoplasms, and most common age group affected is between 15 and 60, and tends to be more common in females. So there's a pathogenesis is believed to be multifactorial. It has a tendency to develop at sites of surgical scars, especially after C-sections and also intra-abdominal resections, while pregnancy and also oral contraceptives have been shown to be associated with development of desmoids. The exact role of hormonal influence is not fully understood. Approximately 5 to 10% of desmoids arise from the setting of FAP, with the remainder occurring via sporadic mutations in the CTNNB1 gene encoding beta-catenin. So that's why it's so important to stain for these during immunohistochemistry. And in 1951, the geneticist Gardner described the occurrence of FAP with extracolonic manifestations of intestinal polyposis, desmoids, as well as osteomas and epidermoid cysts, and that is now known as the famous Gardner syndrome. So desmoids can be first clinical sign of FAP syndrome. They are divided by location. The abdominal wall is the most common location, while the trunk or limbs are the second most common. Intra-abdominal, consisting of the bowel wall, mesentery, is the least prevalent. And however, desmoids related to FAP occur most commonly inside the abdomen. Studies comparing sporadic to FAP desmoid tumors report the predictors for FAP among patients with desmoids were large tumor size, typically greater than 10 centimeters, intra-abdominal location, multiple tumors, as well as younger age presentation. And again, histopathology, like I mentioned, they are similar to other mesenchymal tumors such as sarcomas and also GISTs, with proliferation and uniform spindle cells, but on immunohistochemistry, pathognomonic for beta-catenin and also negative for any of the GIST and also sarcoma markers as I listed on this slide. So what is the role of FAP screening in this patient?
I think I would just, why don't you answer your own question?
No problem.
And tell us why.
Get things going.
Or why not? You have a few more patients yet.
So based on consensus guidelines, they strongly recommend mutational analysis in the specimens to confirm diagnosis and to guide further workup. It is recommended that patients with desmoids and also abdominal symptoms or who have desmoid tumors in the truncal region should be screened for FAP with colonoscopy or sigmoidoscopy. Now, those with negative screening endoscopies but with a strong family history of polyps should be screened for the APC mutation test. And it's specifically in regards to prevalence of desmoid tumors and FAP, the APC mutation that's specific for the codon 1444 and also 1580 has been found to have a higher prevalence of desmoid tumors in patients with APC mutations.
So did you test this patient?
We did, and she came back negative. So she had the sporadic form, even though the family history was positive for polyps.
And are you going to do any interval surveillance imaging, or are you done?
We're going to talk about the present surveillance and everything like that, but she will be getting surveillance as well.
David, I was just wondering, you recommended testing on tumor, is that right, rather than saliva testing in these patients? Is that what you said the recommendation was for mutations?
From the consensus guidelines, they're recommending from the specimens as well, yeah. But if you don't have a specific specimen, then you can undergo the saliva genetic APC mutation test.
And Imran, do you have any comments from a colorectal standpoint? We may have lost him.
Yeah, you're going to do the genetic test. Okay, keep going.
All right, so second case is a 59-year-old female that presented 3 years after a laparoscopic sleeve gastrectomy with intermittent left upper quadrant and also left flank pain for about 1 month. She ended up getting a CT scan. There's some screenshots of the CT scan, which showed an incidental gastric mass. She did not have any other significant symptoms or significant family history. So she subsequently underwent an EUS, which was significant for a submucosal antral mass arising from the muscularis propria, and this was very suspicious for GIST. So how would you proceed in this post-sleeve gastrectomy patient, considering the technical aspects in regards to this mass?
We need one fellow. Philippe, what do you think?
I'll study the scans carefully to see if we can get a margin without having to do another anastomosis in the stomach.
So David, can you tell us how her weight loss has gone with the sleeve?
So she's done pretty well with regards to the sleeve gastrectomy. She's lost approximately 50 to 60% of her estimated ideal body weight loss. And in regards to the sleeve, based on the endoscopy, there was no obvious major dilation that we could have seen on the endoscopy.
And did you do cross-sectional imaging? Is there a large extra gastric component to this?
We did, and there was no large extra gastric component. This is the CAT scan. These are just the screenshots that we were able to pull.
Is that the tumor there or not? Very proximal? Which part of the stomach? You said antrum, right?
Antral, yes.
That doesn't look antral to me, but.
Well, the sleeve comes down. This is staple lines.
Okay, so just tell us what your options are. What did you talk about doing? What are the options?
So obviously biopsy that's one option, endoscopic biopsy. But again, if it's suspicious for GIST, typically we don't biopsy these, and versus resection. But her case is a little bit different because now she only has 20% of her stomach left compared to a person that comes in with a normal sized stomach. So now you're increasing the risk of stricturing and also narrowing if you decide to go wedge this sleeve out. I mean, this mass out. And depending on the technique that you use for closure, staple closure versus sewing. So, and plus this is located near the antrum. So this is pretty close to the incisura, which is one of the areas that you do not want to narrow, especially when in regards to a sleeve. Just because it increases the risk of developing dysphagia, PO intolerance, GERD, such as for any type of narrower stomach lumen. So we did kind of decide in regards to should we convert her to a different procedure, such as a bypass, and resect the remaining portion of the stomach for the specimen.
So what did you think was the best option and why?
I think based on what we found intra-op, because we did consult her about these potential risks of narrowing and stricturing, as well as a conversion into a bypass. It was all dependent on how her stomach looked and where the mass was physically located when we got it. So we did consent her to go to the operating room for a resection. We chose to do the robotic approach in regards to this, with our ports placed in these configurations with a camera port at the umbilicus, as well as an assist port, 5mm assist port lower down.
David, can I just stop you for just a second and let me ask you what your differential diagnosis was for this lesion?
Currently, we were working with the differential diagnosis of a GIST.
Okay, so you thought it was just, was there anything else to keep in mind? Helen, any other things in this location that we should be thinking about? Helen? Avinoam?
Yes, sir. I'm sorry.
Oh, Helen, any other things in this location we should be thinking of?
In the greater curvature of the stomach along the staple line?
Well, this is, yeah, or in that location, or say this was lesser curvature or, you know, sort of posterior stomach. Anything else outside of GIST?
Oh gosh, I guess, I mean, I guess we could think about like carcinoids and lymphomas at that
Right,
level.
so you could think about a neuroendocrine tumor in this location or a nerve cell schwannoma on the lesser curvature. Just a couple of other things to keep in mind. Sorry, I just wanted to make sure we thought about the differential before you went to the OR.
And a lipoma, but most of those will show up. I mean, most of these diagnoses will be solved by the EUS, which you did. So was your EUS confirmatory, I assume? David?
Based on our EUS, it was confirmatory that it was arising from the muscularis propria, and it was a submucosal mass. So that was a pretty high suspicion for this, and there was no other features that would concern us for the listed differentials that we were just discussing.
So you consented her for both procedures? You left it wide open?
Well, we consented her stating that if we felt that it was appropriate, we would attempt to do a wedge resection of the mass because of its GIST. Based on her anatomy, it was a little bit different because it was a sleeve. So in regards to that, if we felt that it was safe in order to resect it, then we would pursue the wedge resection and closure. But if we felt that we would be risking her a narrower sleeve or stomach with a high risk of developing a stricture, we were going to convert her over to a bypass.
Okay, what happened?
All right, so we ended up taking her, and this is our robotic, let's see, place. Okay, perfect. So we entered, she had some adhesions, gastrocolic that we took down. And the mass was actually on the greater curvature, posterior aspect of the sleeve. Pretty large size, as you can see. But her stomach did look much bigger than anticipated. So as you can see that the stomach has definitely dilated over time for the last 3 years. Some more dissection of the adhesions off of the posterior aspect and also the gastrocolic ligament. Let's speed this up for time's sake. All right, so we then decided for wedge resection based on the initial appearance of the stomach and how wide it was towards the incisura, and also the size of the stomach was much more dilated, as I say. So this wedge resection was done appropriately with what appeared to be appropriate gross margins. So that's the mass there. And then we did a hand sewn closure with a 2-0 running V-lock. And after this was closed, the stomach still again appeared that it was patent and was not narrowed or at risk of narrowing.
So you're trying to close it transversely, is that what you're trying to do?
Yes.
And did you scope the patient intra-op?
We did scope the patient. I'm sorry, I do not have the videos of that. It was a negative leak, and also there was no narrowing at that location either.
Did you send a specimen for frozen intra-op or no?
No, we did not.
And why'd you ask that question, whoever asked it?
I did ask it. I mean, one of the differentials that came to my mind, I mean, I know it's not like the top of differential, but what if it was malignant? What if it was like leiomyosarcoma, for example? I mean, maybe would it change the approach for the procedure?
So the only thing to keep in mind there, Abdulrahim, is that they're not going to be able to tell you that on frozen, right? They're just going to see a spindle cell neoplasm because there can be variations within it. So good point, but hard to put the pathologist on the spot.
Okay.
All right. So final pathology did show spindle cells and proliferation embedded in dense collagen matrix without atypia, and again positive for beta-catenin. So this was consistent with desmoid tumor, which was pretty surprising from the patient's sleeve gastrectomy. So gastric desmoids is extremely rare. It's not one of, so based on GISTs actually are more common in the literature in regards to bariatric surgery. I did a pretty extensive literature review on this, and there's only been 2 case reports that's been published in regards to desmoid tumors found after bariatric surgery. Neither case reports had gastric involvement, and ours did. One had involvement of a roux limb, the JJ, and also BP limbs of a patient that underwent a bypass. The other had a desmoid tumor involving the mesenteric of the ilium and also the cecum. Both cases were treated with en bloc resection, and to our knowledge, this is the first gastric desmoid that was treated after bariatric surgery with a robotic surgery approach. So I just wanted to share that with you guys. Her postoperative course, 2 months later after surgery, she developed some intermittent episodes of dysphagia, nausea, and also vomiting. So an upper endoscopy was obtained. There was no recurrence, but there was a short segment stricture at the proximal antrum. Biopsies were taken of the stricture, and they were negative for any recurrence as well. So what are your treatment options for the stricture in a sleeve gastrectomy patient?
Balloon dilation, I think, is a good option to start with, maybe.
Dilatation or stenting or a combination?
I'll pipe in a little bit since bariatrics is kind of my world, and we do see strictures post-operatively, even in a routine sleeve. So yeah, dilations can be an option. They usually have to be done repetitively to kind of get the result that you want, and it really depends on where it is. So at the level of the incisura, it can be a little bit more challenging because of the curvature of the stomach, and it's not just that it's narrowed, but it's actually the fold there as well. They've actually used achalasia balloons to do these dilations as well, to be a little bit more aggressive, but you worry about perforation, obviously, in that situation. And then stenting would be, I think, the next step to go, like you said. That, I think, is done a little bit more in terms of getting better results for it, because when you leave it in place, it kind of gradually dilates it, and you hope that it'll hold that. And then the final thing that you could try before converting to a roux, essentially to go above it, is that you could do a stricturoplasty as well. So those are all things we've done in the bariatric world to try to kind of address strictures that we see.
So what did you end up doing?
So she underwent a balloon dilatation, pneumatic dilatation. It only took about 2 attempts for the stricture to kind of open up for symptomatic relief, and then she was placed on, obviously, PPIs and lifestyle changes in regards to her diet, which she tolerated pretty well.
So in the end, do you regret that you didn't do the bypass instead, or not?
I think less is better for her in regards to that. Obviously, if in the end she does start to gain weight, she still has an option in regards to converting that sleeve over to a bypass. But even with balloon dilatation, she had symptomatic relief, and it's definitely less morbid to have a wedge resection of the sleeve, close it, and then she develops a stricture, and then she ended up doing better in regards to with the balloon dilatation. So we saved her a procedure in regards to a bypass by doing that.
You don't
Matt,
think
can I
there's
just
gonna
jump
have
into a
any future
question?
problems?
Sorry, can I just jump in with a question for Melissa about the finances of this, Melissa? So if she comes to you and is unable to swallow with this may be a non-bariatric procedure for her, correct? Because if she was overweight, wouldn't it be a great way to back into a bypass without calling it bariatric?
So we can do bypasses even. So one of the more commonly, occurring indications for a bypass in a post-sleep patient now is refractory reflux. And so more and more insurance companies are recognizing that there are technical aspects to this that may lead to consequences that need revision, where it is a gastric bypass. But the indication for it doesn't have to be solely morbid obesity. It is a little bit harder to get that approved from the insurance standpoint. A few years back, it was a near impossibility, but we are seeing it approved more and more commonly and now included in coverage plans for revisional surgery after bariatrics.
Right. And I just want the fellows to hear this, because this is one of the things that we come across, Melissa, with things like, paraesophageal hernias and BMI greater than 35, where obviously you're not going to do a primary repair because that's going to fail. And so do you, just for the group, do you code that as a GJ rather than a gastric bypass in these patients?
If they had a paraesophageal?
Yes.
So often when I get a paraesophageal in a patient that's a candidate for bariatric surgery, I do the paraesophageal repair and a bypass at the same time. And I get that approved without any issues.
Right. Do you code that as a GJ rather than a gastric bypass, though? You actually do it as a bypass. Okay. Okay. Just some important points of the fellows, because we actually do these also, but we actually pre-approve them as a GJ rather than a bypass itself in the morbidly obese, paraesophageal. Sorry, Matt.
No. Keep going.
All right. So, we already went over this through our discussion, but one aspect that we didn't discuss is this, it's called the gastric poem. Everybody knows about poems in regards for treatment of achalasia, but it has been reported as an alternative treatment option for failed endoscopic dilations. It's similar to the treatment of achalasia, where there's a submucosal space that's kind of created, typically 5 centimeters proximal and also 3 centimeters distal. And once the submucosa is separated from the muscularis propria, a 6 centimeter myotomy is then made using endoscopic insulated knife of choice based on the operator. So an overstitch device is then used to close the mucosectomy site, and before and after intraluminal pressures and also diameter are usually checked using an imaging probe that's done endoscopically as well. So it's kind of new. It's been used for gastroparesis treatments, but this was a case report that I came across that's been used for a post-sleeve stenosis and stricture. So I thought that was pretty interesting. Another option for treatment. All right, so on to our last case. This was a 54-year-old female who had a history of FAP, and she underwent a total colectomy with an ileoanal anastomosis when she was much younger, around 15 years ago, and was found to have grade 1 endometrial cancer on for abnormal postmenstrual bleeding. So she was taken by GYN-onc for a lap total abdominal hysterectomy. We were called in intra-op for an inadvertent injury to a small bowel when they entered into the abdomen due to the dense adhesions from a previous procedure. So this enterotomy was actually found in the region of a small bowel that was very adherent and also foreshortened, and there was a fibrotic mesentery that included where the SMA was. So we deemed it unresectable. So decision was made to actually proceed with a segmental resection of the small bowel injury with primary anastomosis. So now that brings us to our next question. How should this patient be managed given her history of FAP and intra-op findings suspicious for desmoid?
Is there any imaging? Do you have any imaging?
No imaging, it was just an intra-op consult. So it was no major pathology from the small bowel resection with the primary anastomosis. Pathology was insignificant. It was not safe to do a closure of the enterotomy that was done. Obviously, it would cause some luminal narrowing, and then she could develop a stricture there. So in regards to this, based on intra-op findings and also the previous history of FAP, desmoid was on our top of our differential based on the mesenteric findings intra-op. So we didn't have any imaging to go by right now. So how would you proceed?
And can you do a primary anastomosis? Can you resect that segment and do a primary anastomosis or not?
Okay, so that I'm talking more about what would you do after the patient recovers from surgery. So the primary anastomosis is already done.
Then okay, all right. So you're out of the OR.
So we determined that we can't resect too much of the small intestine because the SMA was involved, and obviously all of the mesentery is very foreshortened with the SMA involved. So we can't go and do an en bloc resection of the suspicious looking mesentery, obviously because it's unresectable with the SMA. So now knowing that, what would you do and what would you provide for this patient after surgery?
So one choice we have is to refer to multivisceral transplantation. If you have the SMA involved in the root, and you're not able to preserve any of the jejunal branches, that's one option.
But this patient was asymptomatic before you did this unfortunate foray into the intestine, right?
Correct.
Gynecologist.
She had no idea her mesentery looked like this. Exactly.
You still want to do a transplant?
So what about chemoprevention? And so again, the imaging, so once she's out of the OR, you can image her to see how things look. So that's would be one option. And then obviously chemoprevention, I mean, before, if she's asymptomatic, I think that's what Dr. Walsh is getting at. Is chemoprevention an option or not? That's at least what would come to my mind.
Okay. So surveillance first, and kind of take it from there.
No, he's thinking about giving him some chemotherapy. You must have some data on this. You wouldn't say chemo prevention because she already has it, but the question is, can you change the rate of growth, which is the problem in desmoids and FAP?
Sorry to interrupt. This is Edward Cho again. During that small bowel resection, was there anything done to the tumor besides observation? Was there a biopsy taken or anything? Like
no, there was no biopsy taken for the. We were consulted strictly for the inadvertent injury for the small bowel.
So there was a tumor at the base of the mesentery involving the SMA. You guys got rid of the small bowel injury, but just the tumor was kind of, you guys just kind of looked at it and then closed?
So there was no physical tumor. It was just a foreshortened and very fibrous mesentery. So suspicious for mesenteric fibromatosis.
Any thoughts from the other services about a biopsy at that point, or did everyone just kind of take a look at it and then close? Just curious.
Yeah, I brought up the question about a biopsy too, if there was something easy to get to, just because one of the other things to keep in the differential here is some sort of neuroendocrine tumor causing a desmoid reaction, David, is kind of what's going through my mind too, even though the history of FAP is certainly very, most consistent with a desmoid type of process.
Were you there, David?
For this case, I was not, unfortunately.
Okay, well, it's not always the easiest thing to biopsy because it has sometimes a confluent mass to it, and it's so it has a very typical appearance as well. Remind me what they were operating on, the gynecologist. Was it a cancer diagnosis or something else?
Yeah, grade 1 endometrial cancer.
Grade 1. Okay. I'm not sure I necessarily would have biopsied it, but I bet the patient had had a scan before. Most of these people do at some point, so that might have been helpful. Okay, what are the options though in terms of treatment? So to everyone's point, you're not going to give them some sort of therapy without a biopsy, but at least tell us what the options would be. Okay. Assuming it's a desmoid.
So currently, consensus guidelines advocate for a period of active surveillance for newly diagnosed and also asymptomatic tumors. So this is exactly what she has. These recommendations have evolved based on several recent retrospective studies demonstrating a progression-free survival rates of only 50% at 5 years for asymptomatic patients managed with active surveillance. And also even a spontaneous regression even reported in 1/4 of desmoid tumors. So active surveillance includes a clinical exam, a thorough clinical exam, and also a radiographic assessment, either a CT scan or MRI. Typically, this is done every 3 to 6 months for 2 to 3 years, and then every 6 to 12 months thereafter, as long as there's no progression or symptom development. So she did receive CT scans 3 to 6 months afterwards, and they have been completely stable with no increased size or symptomology coming from what we found intra-op. So now currently surgery is indicated for symptomatic tumors, tumors that impair function, progressive disease on medical therapy in emergency situations such as obstruction, ischemia, or perforation. However, due to progressive nature of actual desmoids, they have a higher prevalence of recurrence even with satisfactory margins. The strongest factors predicting recurrence after resection have been reported to be very large tumor sizes, mesenteric or extremity tumor sites, as well as the younger age of presentation. So advanced intra-abdominal desmoids can cause significant complications that sometimes require emergent operations. And when deciding on surgical resection, it is imperative to kind of consider the tumor size, location in the mesentery, and also surrounding vital structures. So for her involvement in the SMA, we were not going to be resecting. Aggressive resections is also associated with higher mortality and also morbidity, such as short bowel syndrome. And somebody discussed earlier in regards to transplant. So if you do resect small bowel, and you have to based on emergency situations, intestinal rehab, chronic TPN use, and also dependence, and even intestinal transplantation may be required, especially if you're leaving behind less than 60 centimeters of small intestine. So the decision for aggressive resection must be individualized to prevent significant morbidity. So that brings us to our next question. And, obviously everybody wants negative margins whenever you resect, especially end block resections, but is it that important? Are negative margins important when we're talking about desmoid tumors? What are everybody else's thoughts?
Imran, what do you think?
I think, again, it's a risk-benefit thing. If you can get it all out safely, I would, if you can. Depends upon what you're going to sacrifice intraoperatively. So, again, that's not really a very good answer, but it depends upon what the intra-op findings are.
Yeah, it really depends on if it's FAP or sporadic. So in FAP, you're never going to get a negative margin. Just forget about it. So that's why you really have to know what the scenario is. And, fortunately, very few people, same disease, right? But a sporadic patient like your first patient versus an FAP patient is totally different. And there are ways to stage desmoids in FAP, and there's a high grade 4, a higher grade lesions, and their overall mortality rate is 50%. So those are the ones that you're going to consider intervening on.
Matt, I think LK is giving us a 3-minute warning, so we probably need to wrap it up because I think we're due to be kicked off fairly soon.
All right, so I'll quickly go over. It's only a couple more slides. So we've just discussed, R0 resection was traditionally the main goal, but there's been conflicting data on the significance. There was a study out of MD Anderson with 2 cohorts, one in 1965 to 1994, and also the second cohort from 1995 to 2005. And they actually showed there was no effect on recurrence-free survival, and there's no prognostic significance between R0 versus R1. So it remains a controversial topic. In regards to radiation, XRT has been used for both adjuvant and also definitive therapy, especially for extra-abdominal desmoids. But XRT is not frequently used for intra-abdominal fibromatosis due to the high risk of XRT-induced enteritis, as well as the lack of the distinct target for grossly resected disease. So a lot of people were talking about systemic therapy. Somebody mentioned chemoprevention. So hormonal therapy and NSAIDs has been widely studied. It's the first-line systemic therapy for unresectable, recurrent, or progressive disease. Typically a tamoxifen is used, and also as well as an NSAID. It's inexpensive, has low risk of side effects, and reported response rates of greater than 85%. Now, chemotherapy is desmoids are typically not chemosensitive, but there have been combinations with anthracyclines, which have been appeared to be most effective. Other combinations with methotrexate, vinblastine, have also been equivalent efficacy with reported symptomatic relief of 80% of cases, as well as median progression-free survival of 75 months and even 136 months for responding patients. And then now the last but not least, the most important one is the tyrosine kinase inhibitors, which have been the most promising class of drugs. Imatinib, sorafenib, and also pazopanib have all been found to have significant improvement in progression-free survival. And these are the most promising class, as I discussed. So in conclusion, there's been a paradigm shift in regards to the treatment of desmoids. It used to be an aggressive surgical approach to a more conservative approach now. There has been proven efficacy of systemic therapy, but questions still need to be answered, especially which therapy has a higher rate of partial response to select the best treatment in symptomatic cases, requiring rapid disease shrinkage, and also understanding more of the genetics, molecular, and also clinical factors to predict the best treatment. As well as this, in regards to, it must be stressed that most of these patients affected by desmoids already have a very long-term outcome. So with survival times of decades after diagnosis. So quality of life is crucial and needs to be taken into account when selecting treatments, especially if considering surgical resection. So I just wanted to thank my program director, Dr. Bagloo, and also assistant program director, Dr. Pozzessere, for the guidance and also leading up to this presentation. And I want to thank the SSAT and everybody who participated tonight for this presentation of our cases that we were able to share with you. And hopefully this was informative review of a very rare disease process. Thanks again. Any questions and comments?
I just want to say, I think this was a great overview that was case directed, but with data, David. Thank you so much for that. Dr. Walsh, thank you so much for moderating this, especially on short notice and on a very unusual topic. I really appreciate everyone showing up. LK, this will be, this was recorded and will be available, right, somewhere online?
Correct. It will be available on the fellows page. Once the webinar concludes, we'll post it.
Great. And Dr. Bagloo, you should be very proud of your fellow. You did a great job, David.
Thank you.
Thank you all so much.
Thanks again. Good job. Have a good night.